Hello, and thank you for being a part of the 20th Preston Health Mealer. My name's Karen Partington and I'm the Chief Executive of Lancashire Teaching Hospitals NHS Foundation Trust. Now more than ever, healthcare is in the spotlight and individuals are more conscious of how their choices impact themselves and the people around them. Education is key to improving health outcomes, and I believe it's vital that everybody is able to access the information they need to make informed choices about everything from healthy eating and exercise to Covid-19 vaccination and knowing when to seek medical help. The Health Mealer plays such an important role in making this possible, and I commend the National Forum for Health and Wellbeing for creating this educational forum. Over the years, this event has brought the hospital to the community, helping to diagnose conditions like diabetes and cardiovascular disease through testing and education, often before the individual has sought advice themselves. And it's opened the doors of our boardroom, showing how members of the community can influence the way that we work by becoming trust members or governors. I retire at the end of this year, meaning that this will be my last Health Mealer as Chief Exec of Lancashire Teaching Hospitals. But the partnership between this trust and the Health Mealer will continue, and I look forward to seeing a very long, productive and fruitful relationship in the coming years.
I would first like to thank Professor Gupta for inviting me to speak to you on the lasting impacts of Covid-19 pandemic. Those watching who are health and social care professionals will know that the impacts of Covid-19 are far more wide-reaching than the initial infection, and that we must work together to address the long-term implications of the virus. These professionals will also recognise the immense pressure that is currently facing the public health and the health and social care workforce. I thank all of you for your commitment to protecting the health of your patients and the populations you serve. The lasting impacts of COVID-19. We do not know enough yet about the prevalence of long COVID or how the health of those infected with the virus could be impacted into the future. There are a range of estimates on the number of people living with long COVID, with a recent poll from the Office of National Statistics estimating that 1.1 million people in the UK were experiencing long COVID in the 4 weeks before March the 6th, 2021. We also know that people have experienced poor mental health as a result of stress, uncertainty, bereavements and isolation. These problems may have a particular impact on our young people who have had important development of the years of their life disrupted by the pandemic. The Office for Budget Responsibility has said that the UK borrowed 355 billion during the 2020-2021 financial year. This will impact on us for generations to come. The OBR has also predicted that the unemployment rate could rise from 6.5% of all workers representing 2.2 million people during 2021. COVID-19 is a global problem. Countries with less developed health systems will find it harder to be able to contain the virus and could suffer the impacts of COVID-19 for years to come. We cannot tackle the virus in isolation and must have equitable access to vaccines. Until this is achieved, we will continue to face human and economic costs of COVID-19 globally. These problems are not experienced equally. Even before the pandemic, communities across the UK we're facing stalling life expectancy, rising poverty, and widening of health inequalities, problems which have been exacerbated by COVID-19. The Public Health England review into ethnic disparities in COVID-19 showed that critical care admissions was 28% more likely in South Asians and 36% more likely in Black ethnic groups compared to the white group. And the risk of death was between 10 and 50% higher amongst BAME communities compared with people of white British ethnicity. We also see from this chart that mortality rates for COVID-19 follow the social gradient. That means that people in the most deprived areas are going to be more likely to die as a result of COVID. People who work in low-income jobs in the caring, retail and service sectors have been more exposed to COVID-19 as they have had face-to-face jobs and that cannot be done from home, and overcrowded housing in densely populated areas have added to their increased risk. Poorer communities have also been vulnerable to severe disease once infected because of the higher level of pre-existing illness, and increased rates of infection have led to greater loss of impact. We must continue to have access to the vaccine. Research from the Royal Society for Public Health has shown that those from Black, Asian, minority ethnic groups backgrounds have over 20% less likely to accept a COVID-19 vaccine than the white respondents to these studies. The same research has shown that while 84% of the highest earners would accept a COVID-19 vaccine, this number drops to 70% amongst the lowest earners. This research, when considered alongside last year's Public Health England report, showing that those from minority ethnic communities are significantly higher risk of severe illness and death from COVID-19, demonstrates the importance of a dedicated effort to support vaccine uptake amongst the marginalised communities. We must also work with our international partners to ensure that global access to the vaccine. Only through this approach can we hope to tackle the COVID-19 pandemic and protect our health into the future. Unless the whole world is safe, none of us will be safe. How do we recover from COVID-19? It is important to understand that all healthcare interventions, if not properly run, the risk of causing further disadvantage, if not delivered properly, will run the risk of causing further disadvantage. If we do not achieve vaccine equity, for example, we will only see health inequalities widen. We must take steps to support those marginalised communities who have faced the worst impacts of COVID-19. The number one priority in the WHO manifesto, the World Health Organization manifesto for a healthy recovery from COVID-19 is to protect and preserve the source of human health, nature. Increasing numbers of infectious diseases, including HIV, AIDS, SARS, Ebola, and now COVID-19, have made the jump from wildlife to humans. If we neglect environmental protection and disregard our interconnectedness with the natural world, this trend will only continue. But we must also work together to ensure global access to basic healthcare services. Hand washing facilities are essential for the prevention of infectious disease transmission, but are lacking in 40% of households across the world. The UK must continue with its commitments to work with our international partners to level up healthcare globally. So in conclusion, it is clear that we face significant challenges in responding to the long-term impacts of COVID-19. We must work together to protect the lives of all in society and must take forward the lessons learned in our response to this pandemic so that we are better prepared, much better prepared into the future. Once again, I thank Professor Gupta for inviting me to speak today, And I thank the public health and social care professionals who are all working so hard to save lives. Thank you, everyone.
Hello, Namaste and Jai Shri Krishna. My name is Dr. Neelam Patel and I'm a consultant anaesthetist at Wrightington, Wigan and Lee Teaching Hospitals. I would like to thank Professor Gupta for inviting me to speak about my professional and personal experiences of the pandemic. In March 2020, we began to make preparations for our first COVID patients. This initially involved training, movement of staff, patient and equipment. From the end of March, when our first COVID patient arrived in ICU, my work pattern changed completely for the next 8 weeks. As anaesthetists, we are responsible for looking after patients on the intensive care unit, and we had to provide consultant cover 24/7. Our ICU soon became full, and we had to expand rapidly from 11 to 21 beds. At the same time, some of our colleagues and friends also began to become unwell and had to self-isolate. This brought about a deep sense of fear and anxiety amongst us all, and some of us even moved out of the family home in order to try and reduce the transmission of COVID from work to our loved ones at home. I was also considering this and had to have a very difficult conversation with my husband about what should happen in the event of me becoming seriously unwell with COVID. As doctors, we weren't used to dealing with this volume of sick patients who we could not save, and the death toll had an impact on us all. Two of the patients that stand out for me were a husband and wife who were admitted at the same time, but initially to different wards. It soon became clear that the wife was becoming more and more unwell, and we had to call her family in. The palliative care team managed to move her to the bedside next to her husband, and they held hands while she sadly slipped away. It was also their wedding anniversary on the same day, and the staff played some music from their wedding to them both. After a short time, her husband also died, surrounded by his family. Whilst we weren't able to save these two patients, I hope that we have been able to give them a dignified death. Sometimes, however, we weren't even able to call the patient's relatives in because they deteriorated so rapidly. As a doctor, it's one of the most hardest things to do, to call a family and tell them over the telephone that their loved one had died. On a personal level, I was also affected by COVID. In March, my son, who was at university in London, attended a social event. Shortly after this, he became unwell, and although testing wasn't available at the time, he was likely to have contracted COVID. He called us one night from his flat to tell us that he'd called an ambulance to take him to hospital. As you can imagine, to be so far away and not be able to do anything was so heartbreaking for my husband and I. And he wasn't able to travel home at that time. Fortunately, he did recover without having to go into hospital, and seeing him come home after a few weeks was one of the best gifts we could have had. At the end of April, my uncle sadly passed away after contracting COVID whilst being in hospital. At the time, only 10 people were allowed at the funeral, so I couldn't go. Normally, a family comes together at times like this. So because we couldn't, it made the grieving process extremely difficult, especially for his children. At the same time, I also contracted COVID, but fortunately only suffered with a loss of smell, no fever or cough. However, at the time, because loss of smell wasn't recognized as a symptom, I carried on working and also didn't isolate at home. So I feel blessed that my family did not catch it from me and didn't suffer in any way. My experiences in the last 12 months have had both a positive and negative impact on me. The negative aspects have been a sense of helplessness when we can't save patients, grief over the loss of dear family and friends, and a deep sense of anxiety when I see people not obeying the rules and putting themselves and other people at risk. There have been some positives, however, and I'd like to end on that. Firstly, when I contracted COVID, that none of my family suffered because of me and my work. Secondly, it has also meant that my two sons who were living away from home came home to be with us. It's very reassuring knowing that they're safe and well. It does mean, however, that apart from being at work, when I'm at home, I'm cooking for a family of 5. And believe me, that's never ending. Finally, I think many people have come to the realization that it's not about having material things around you that gives you a sense of happiness. It's knowing that your loved ones are safe and well and that you have been able to make a positive difference to someone's life. That gives me a sense of happiness and contentment. I wish you all health and happiness. Please make sure that you have the vaccine. Take care and stay safe.
Hello, everybody. My name is Mohammed Bhanavar. I'm a consultant chest physician at Lancashire Teaching Hospitals, Preston. It's such a pleasure to be invited to speak on a topic which is of great importance today, which is evidence-based management of COVID-19. This is a massive topic, and I'll only be able to cover the essential headlines with regard to this topic as of today, which is 26th of April, 2021. I will cover this topic under the following headings: a brief introduction, followed by an overview of the clinical features, focusing then entirely on management and in particular specific therapies and studies which have been carried out in this condition, and conclude the topic. All this in a matter of 10 minutes or so. COVID-19 has been around with us for more than a year and unfortunately has caused tremendous devastation, disability, and death across the globe. Almost every country has been affected, and as you can see, does not respect position or royalty. In the UK, the numbers have been going up and down. We've just fortunately coming down from the second wave, and the number of deaths also fortunately coming down at the moment. But it's not yet time to lower our guard. This is a devastating illness, and the clinical features when the patients present to us in the hospital can vary from very mild disease, which is treated at home most of the time, to very severe disease. There can also be asymptomatic carriage. Common clinical features, as you're all aware, vary from fever to dry cough to myalgia, loss of taste and smell. But the most important points to remember if you're treating COVID at home is you need to monitor the respiratory rate and also oxygen saturation. If the oxygen saturation drops below 94% or drops by 4% from baseline, you've got to take action with regard to the treatment of COVID. And those patients may require hospitalization. Vast majority of COVID patients otherwise can be managed at home. Now, classically, these patients present when we come to hospital with some blood test abnormalities, including drop in the lymphocyte count, raised CRP, and a number of other derangements, quite specifically increase in the D-dimer level, certain other measurements such as ferritin, troponin, and procalcitonin, which I will come to in a minute, also of relevance. We have some prognostic indicators in the form of troponin rise, D-dimers, and ferritin, and also IL-6, which we tend to measure these days. Most of these patients only require a chest X-ray, and chest X-ray produces classical features in COVID pneumonitis. There is a very small role for CT scan. CT scan is not to be done routinely when patients come to hospital. The role of CT is where there is a diagnostic dilemma or where there are complications, and very occasionally when you suspect thromboembolism, then a CTPA may be of use in carefully selected small number of patients. If a CT scan has been performed, there are some classical features which are seen in COVID, varying from peripheral ground glass opacities to consolidation to what we call as crazy paving appearance, and so on. Extremely important to do an early RT-PCR swab and isolate the patient accordingly when you see them. There is not a major role for antibiotics in COVID. This is a viral illness. One marker, surrogate marker, which is useful is the measurement of procalcitonin. And this, if it is normal in the first instance, can be repeated after 24 hours. And further on, if required, it helps us to decide whether a patient requires antibiotics as well as when to withdraw antibiotic therapy. Moving on to the management of COVID, it's a viral illness. So the main management is supportive, symptom control, and effective hydration. If the patient becomes hypoxic, then you have to set targets as to what target. Most of the time, we set a target of about 94% for these patients, unless they have underlying lung disease such as COPD, where the target needs to be set lower at 88% or so. Mobility is important wherever possible in the house, because you do not want to encourage the development of clots in these patients, and thromboprophylaxis where appropriate, which I'll touch upon very shortly again. An incredibly important maneuver, simple maneuver in COVID, is the use of proning. Now, proning is not just lying on the tummy, which is the most important bit, but also shifting from the tummy onto the right lateral semi-recumbent position, left lateral position, and back to prone position. This makes a massive difference, and in fact is more effective than any other medication in COVID patients. Antibiotics, as I mentioned, very small role of antibiotics in selected patients. Specific therapies, the only proven specific therapy to save patients' lives in COVID is dexamethasone. Besides that, there may be a role for tocilizumab, which I'll come to. Very small role for remdesivir. It's certainly not a magic pill. It's certainly not a life-saving medication. And then, if the patient is deteriorating, deciding as to how to escalate care to either to the respiratory high care unit or to the intensive care, which patients will benefit from it, is something you need to discuss with the intensive care team, and as a multidisciplinary team, decide on the best way forward for those patients who are deteriorating. Now, this is a complex slide, and we do not have to go through all of this, but just to indicate that is that you need a very systematic approach to decide as to which patients will benefit from support, respiratory support in the form of high flow nasal oxygen, or CPAP, as we call it, continuous positive airway pressure, and only a small subgroup of patients, small percentage of patients, may be considered for intubation and mechanical ventilation. So we take a very systematic algorithmic approach. And the other aspect, other incredibly important aspect in COVID management is use of effective thromboprophylaxis. So in standard risk patients, as we risk stratify them, we use prophylactic low molecular weight heparin. In higher risk patients, we use a higher dose of the prophylactic low molecular weight heparin. Where there is a doubt, if there is a high risk, then only then we will carry out a CT pulmonary angiogram and consider therapeutic doses of anticoagulation. All of this, in the interest of time, I should mention, if you wish to access more resources, you can go to the British Thoracic Society website, where a team have been working round the clock throughout the year to produce guidelines for absolutely everything that you need to know about COVID-related pneumonitis and various aspects of its management. It's free to download. You can go to the British Thoracic Society website. You can Google and download these resources. Coming to specific therapies, COVID has led to an explosion of research in this area. More than 5,000 studies have been carried out in COVID, and there have been more than 120,000 publications already in the field of COVID-19 over the last 12 months. Now, why? Because so many medications have come and gone in the treatment of COVID, everything from hydroxychloroquine to the antiretroviral drug to the simple antibiotic azithromycin, plasma therapy, colchicine, aspirin, Regeneron antibodies, and so on have been tried. None of these have been shown to work. Some others have still being tried, like the rheumatoid arthritis drug baricitinib, dimethyl furoate, nebulized nitric oxide, and a number of other medications as well are being tried. Most of these have not worked thus far, but have to wait and watch. But the headline news is that the only medication, as I said, is dexamethasone, which reduces mortality, improves the chances of survival, reduces the need for intensive care treatment in these patients. The one other medication is tocilizumab, small role for remdesivir in selected patients. Let's look at this in a little bit more detail because it's important. The most important trial, or the largest trial worldwide in COVID, has been the recovery trial from the University of Oxford, a multi-center trial, more than 170 centers in the UK alone, and a number of drugs have been studied already. Nearly 40,000 participants have very kindly participated in this trial, and various drugs, as I mentioned earlier, azithromycin, hydroxychloroquine, and antiretroviral drugs have been found not to be effective in COVID thanks to the recovery trial. And again, plasma also has not been found to be effective. We await results on some of the other medications that are being tried, but what has been proven to be effective, as I said, is dexamethasone. Hydroxychloroquine ruled out because of recovery trial. The other HIV drugs ruled out. Azithromycin ruled out because of this. And of course, the other big trial, the massive trial, was the Solidarity trial from WHO. Again, this particular trial showed that certain drugs, again, do not work. Now, coming to convalescent plasma, which was celebrated and a lot of hope was held out for the use of convalescent plasma in COVID, it has been proven now with a number of studies that convalescent plasma did not improve survival or other pre-specified clinical outcomes in this condition, unfortunately. So not much of a role, hardly any, in fact, no role for convalescent plasma. Is there a role for remdesivir? This drug has been available for quite some time. The role, I would say, is small. It is definitely not to be considered as a miracle, magical, life-saving drug. What it does, according to this study, is reduces the time to recovery from COVID in milder illness. However, there's a great deal of debate because the WHO Solidarity trial did not show any significant benefit with the use of remdesivir. So in the UK, what we tend to do is remdesivir is used only a very small, used in only a small minority of patients, those who are hospitalized, not those who are at home. Those who require supplemental oxygen are within 10 days of onset of symptoms, and they have no other contraindications to the use of this medication. So only those who are mild in low flow oxygen, we use this drug. And again, it's not been proven to be a life-saving drug, so it's not absolutely essential to give this medication. What you definitely need to do is to give dexamethasone, but again, only in those patients who are hypoxic. Only patients with COVID who have hypoxia, that is, the oxygen saturation has dropped significantly, benefit from low-dose dexamethasone. Others may, in fact, have more side effects rather than benefits with low-dose dexamethasone. This has been conclusively proven by the recovery trial, where it has been shown that it reduced the deaths by 1/3 in ventilated patients and by 1/5 in patients who require oxygen. Those who did not require oxygen did not benefit from dexamethasone. What about tocilizumab, the only other drug which has recently been shown to be of benefit to improve survival? Again, there's a bit of debate because the smaller initial studies did not demonstrate any significant benefit, but the larger studies recently, the REMAP-CAP trial, and the most recent one is the recovery trial with more than 2,000 patients, showed that there was a mortality benefit, a survival benefit with regard to this medication tocilizumab, an anti-IL-6 receptor antagonist, and it also led to improvement and quicker discharge from the hospital on that basis. So what do we do in the UK? Looking at all the evidence at the moment, tocilizumab is used only in a small select group of patients. Those who are in the hospital, hypoxic, have been given dexamethasone, but are deteriorating and are due to be transferred to the high dependency unit or intensive care unit only in those patients and only within the first 24 to 48 hours of the transfer to the intensive care unit. So it's a very small select group of patients who will benefit from this. A number of other drugs are being studied around the world in multiple centers around the world, like in the REMAP-CAP trial, for instance, or the principal trial, which is a trial in the community for primary care in COVID. And these patients, for instance, it's been shown more recently that perhaps an inhaled medication, inhaled steroid, may help in improving the recovery time in non-hospitalized patients with COVID-19. The milder end of the spectrum, maybe we should be giving inhaled steroid. So in conclusion, COVID is a viral illness. It has got a viral and an inflammatory phase. The most important bit is supportive therapy and then monitoring for hypoxia, effective oxygenation should hypoxia occur, should the oxygen level drop, preventing hypoxia, the use of early proning, breathing exercises, proning at every stage of the illness is crucial in COVID, and then respiratory support, that is, if necessary, moving them to intensive care or high dependency unit, risk stratifying those patients very early, preventing clots, treating other complications, very, very close collaboration in the multidisciplinary setting with critical care unit. Specific therapy, the most effective is dexamethasone, but only in those patients who have had a drop in the oxygen saturation. Small role for tocilizumab and a very small role for remdesivir. The key is to enroll patients into clinical trials so that we can get better and more effective treatments in the future. In the meantime, as far as COVID is concerned, we must remember that we must take all due precautions, and in fact, no one is safe until everyone is safe. Many thanks for your kind attention.
Hi, my name is Dr. Sharda Gudur. I'm one of the respiratory consultants working at Lancashire Teaching Hospitals NHS Foundation Trust. I want to share my experience of managing COVID-19 patients from the hospital perspective and the impact this has had on our service. COVID-19 was labeled as a global pandemic in March 2020. We know that we have a significant number of patients with breathing issues in our catchment area. Having a virus that affects lungs in such patient population became a concern. As a new disease then, services needed to be planned to manage COVID patients at hospital discharge, which was an additional impact on our existing services. Therefore, services needed to be accommodating to manage such patients in an innovative way without compromising patient safety and pick up on any potential post-COVID complications such as scarring on the lungs, blood clots on the lungs, and other such complications. A multidisciplinary team, in short MDT, was put together, which included specialist chest physiotherapists, airways speech and language therapists, redeployed respiratory trainee doctors, physician associates, advanced nurse practitioners, and respiratory consultants, including myself, started managing the post-COVID patients who were discharged from our hospitals, both Preston and Chorley, by setting up a virtual telephone follow-up. This included patients discharged from both medical and non-medical wards, and this was to holistically assess patients for ongoing symptoms based on national guidelines. The team has worked very hard to provide specialist holistic virtual care to COVID patients who have been discharged, supporting them with any ongoing respiratory symptoms that they may still be experiencing. The virtual aspect helps to avoid face-to-face meetings and therefore prevent the spread of infection while supporting the patients in what can be a difficult recovery process for a long period of time after discharge. The MDT have managed to conduct telephone consultations for patients since the start of the pandemic, giving them the opportunity to voice any ongoing health issues, any concerns, and providing them with the support they need to return to their normal life. All of the triaging and initial support provided by the MDT is COVID secure, as all of the appointments are taking place via telephone call. The face-to-face appointments are only initiated in cases where virtual follow-up is not practically possible and indicated based on the severity on initial consultation. This will be after investigations, usually such as X-rays, CT scans, detailed breathing tests, heart scans, etc., particularly for patients who've been admitted to intensive care and our respiratory high care ward, or other patients who needed support, including breathing support such as CPAP machine. This also gives the patients the reassurance to attend follow-up as they know why they are coming into hospital environment. After a great deal of learning from the first wave, it became very clear that many patients required support after their discharge from the hospital. Our hospital came up with an online user-friendly COVID resource pack for patients and carers, including breathing exercises, dietary advice, any swallowing issues, and general tips on their rehabilitation journey. This patient-friendly resource is updated on a regular basis and is very helpful to both hospitalized patients and also for milder patients who were managed at home. As we started to know more about the COVID illness, we became more aware of the multi-system nature of this infection and that it affects different people in different ways. Patients with coexisting conditions needed more support so that they do not become deconditioned or develop complications. So we developed a quick network within the hospital specialties, particularly with frailty team, to ensure patients were being appropriately followed up. We also ensured patients with other organ involvement, such as kidneys and heart, are signposted to the right support. We also developed partnership with our neighboring organizations, such as in Lancashire Care, commonly known as Minerva, to help with our COPD and heart failure patients. We are also ensuring that there is a safe transfer of care when we refer patients to further rehabilitation, and also offer psychological support with Mind Matters at Minerva from our virtual post-COVID team. With this, our pathways to manage patients also change accordingly when we also transfer the care back to the primary care, such as the GP. So far, we have managed to discharge more than 2,500 patients from both Preston and Chorley hospitals, and the patients have given valuable feedback that they have felt supported by our service. As part of Health Mela campaign to improve the health of the local population, I would like to highlight that we want to raise awareness that you do need to seek help if you have ongoing symptoms such as breathlessness, cough, chest pain, palpitations, fatigue, or such complaints following possibility of COVID infection. Please seek medical attention and advice from your GP for an assessment and support. Thank you for giving me the time to share my experience.
Hello, and thank you for giving me this opportunity to be talking about COVID-19 in this webinar. First introduction, my name is Dr. Taneja. I am a lung specialist, that is a pulmonologist, but also I'm an intensive care doctor and I work in the ICUs. And as a result of my profession, fortunately or unfortunately, I've had close dealings with COVID-19 right from the outset. I work at Medical College of Wisconsin at Milwaukee in the United States. And we had our first COVID patient sometime in March last year. And as all of you can imagine, the disease was unknown at that time and is still unknown um, for for a lot of other reasons. However, from the beginning, we really did not know what to do in the ICU, and lots of times we got very contradicting advice from the medical literature. So, for example, right in the beginning, what isolation to do, what personal protective equipment to wear, what PPEs are available and what are not available, were huge challenges. But from the patient care perspective, what really to do for those patients when they get really sick in the ICU? Should they get antivirals? Should they get antibiotics? Should they be intubated if they're having respiratory failure and sick enough, and they're sick enough such that they're in the intensive care unit? But the purpose of my discussion today is to move forward. The challenges that were faced initially are well documented, and the challenges that the healthcare workers faced, particularly the ICU and the emergency department nurses and doctors, have been well discussed. So today what I'm going to talk about is the long-term sequelae of patients who survive COVID. And before I get into that, I'm going to digress for about 1 minute away from COVID. I'm going to talk about an entity called post-ICU care syndrome. Once again, this is unrelated to COVID for now. Let's just digress for a minute. So the intensive care researchers over the last 15, 20 years, not just in the United States or United Kingdom, but all over the world, have realized that as our healthcare has gotten better, a lot of patients survive critical illness. So what really happens to them if they survive? So we'd use a case example. Let's say you have a 60-year-old man who has pneumococcal sepsis, old-fashioned bacterial pneumonia, and they get really ill and they're in the intensive care unit requiring oxygen, and that's not working for them, and they end up on the respirator. And they spend 2 weeks in the ICU on mechanical ventilator, during which their kidneys weren't working very well and they required dialysis, and hopefully they get over it. What happens to this man if he survives this? What happens to him in 6 months? What happens to him in a year? And the researchers all over the world, but particularly initially in Canada, found that even when patients survive really life-threatening critical illness, their long-term sequelae can be divided into two broad categories. One, which would be easy to understand for a common man. So if somebody had a bad pneumonia, and maybe they'll have some scarring in the lungs. Okay, easy enough. Their kidneys failed when they had acute illness, so maybe they'll have some long-term kidney damage, and their kidney numbers would be slightly off. Okay, fair enough, easy to understand. What the researchers found was the survivors not only had chronic sequelae to the organs that were affected, but they had unexpected sequelae. So, for example, the survivors would often say they have trouble sleeping, and they have chronic pain, and they have nightmares, and they wake up in the night because they are having bad dreams, and they're reminiscing their ICU stay, not in a good way. So, they are, in their dreams, they are having pain, or they are reliving or re-listening the bells and whistles and alarms of the ICU. Lots of patients have neurocognitive issues, so they have memory issues, difficulty concentrating. Patients, for example, have physical issues, so generalized weakness. Not just deconditioning in that they feel weak, but on objective testing, they have degrees of neuropathy or myopathy. So fast forward to COVID. So remember, what I was talking about was what we knew even before COVID. So fast forward to COVID. A COVID patient who's in the ICU not only has all the challenges that we just talked about, but in addition, they face a challenge of isolation. We put these people in isolation for a significant proportion of their hospital stay and ICU stay. They're not allowed visitors. The healthcare workers who entered the room, the therapists, the nurses, the doctors, enter the room covered in head to toe PPE. Their faces are covered with masks, their eyes are covered with goggles. And so much, the communication that they're having with the healthcare team is through a mask. Sometimes they can understand what's going on, and sometimes they can't understand what's going on. So it's not hard to imagine how before COVID, if somebody who survived ICU had a risk of post-ICU care syndrome, a COVID ICU survivor would probably have a much, much higher risk of post-ICU care syndrome, and which, as I highlighted before, would entail some neurocognitive issues, memory issues, physical deconditioning, generalized weakness, but also psychosomatic and psychological issues. So anxiety, PTSD, unexplained pain, things like that. Since my time is limited, let me move to my next point, which I want to make right now. So we talked about the ICU survivors. How about the vast majority of COVID patients who we know will not get sick enough to be in the hospital? And that's fortunate, that's good. So we all know that, we've all heard in the media, and we all know that it's a viral infection, and vast majority of people who will have COVID will have mild symptoms. Only a small fraction will have serious illness, and even a smaller fraction will end up in the ICU. And so we just talked about how it's not hard to imagine that somebody who was sick enough to be in the hospital or the ICU would have long-term sequelae. But how about long-term sequelae for those people who have mild illness?
Hello, my name is Piyush Patel. I contracted COVID-19 in March 2020. Unlike most people who recover after a few weeks, mine was a much severe attack. In fact, I ended up in hospital, taken away by ambulance on the 4th of April, and was diagnosed with COVID pneumonitis. It's a very severe form of COVID attack, which resulted on me spending more than 2.5 months in hospital from the date I went in to being discharged. When I was admitted in hospital on the 4th of April, I was very ill. I couldn't even walk down the stairs to the ambulance. They had to carry me downstairs from my bedroom, where I've been self-isolating for nearly over 4 days before I became severely ill, where my oxygen levels were very poor, and the ambulance staff decided that I needed to go into hospital. It was a tremendously scary moment. I did not want COVID, and I kept insisting that I didn't have COVID, simply because I was very scared, didn't want COVID, didn't want to leave my family, didn't want to go to hospital. I simply didn't want to be in hospital with COVID, but ultimately I had no choice, and I was taken away by ambulance on the 4th of April around 7 p.m. And when I saw the ambulance doors close and I was watching my family standing at the door of my house, I simply thought I would never see them again because of what the pain I was going through. My first symptoms started on the 22nd of March when I started coughing, but at the time the advice that was being given was that if you had a dry cough and a temperature, you more than likely had COVID-19, and you had to self-isolate, and then hopefully over a number of days you would recover. Sadly, that wasn't the case. As I said, I was taken away by ambulance on the 4th of April into Royal Preston Hospital, where the staff began to prep me up for what I thought, what I didn't think was going to happen was ultimately end up in the critical care unit in Royal Preston Hospital. They put a hood on my head, which again increased my anxiety. I was very, very scared because I'd seen pictures on TV where people were sitting in corridors with the hood on, and stories of people not making it. With the hood on and all the preparation that took place before I was moved into ICUT, I had to have a catheter, a blood line put in, which was extremely painful, especially one where they put one in the wrist, in the artery. But it was something I needed for them to monitor. They tested me for COVID-19 by swabbing the back of my throat and my nose, but we didn't know the results. Obviously took a lot longer. In the end, after having the hood on for a time, time, after all the x-rays were taken, with restricted number of hospital staff within my room due to COVID-19 restriction, I was eventually told I had to go into critical care. And again, I was beginning to worry even more, because I have seen relatives who've gone into critical care, and unfortunately not all of them have made it. So my mind was playing back all the events of my past relatives who'd been in critical care units, and eventually I was wheeled into critical care, where their staff were incredible in resting me to assure me that all will be well, and they just have faith in them. COVID-19 was a new form of disease, and they were doing their best to treat me. I managed to remain on the hood for almost 12 hours, and on the 5th April 2020 in the morning, I was told that remaining on the hood was not sustainable, and I had to be put on the ventilator and sedated. I had no choice but to have faith in the hospital staff and the critical care unit that were dealing with me. I even jokingly asked how long would I be, and a little thinking that it'd only be a few days, but that was just a moment to sort of relieve my fears. I was constantly thinking what my family must be going through, wondering what was happening. I was constantly getting messages on my phone, which I was still able to answer, and I told them that I was going on a ventilator, and I think everybody just started praying. I had a number of people who have prayed for my recovery, ranging from friends, family around the world. Even my neighbors were praying for me. They were holding little prayer sessions in the churches. I've known people in Uganda have prayed in a mission for me, because my neighbors were worried about my health condition. People at the Gujarat Hindu Center sang Hanuman Chalisas for me, and I'm so deeply humbled that I'm part of a community that cares for me so much. As I said, I was put on the ventilator on the 5th, and all I remember after going to sleep was waking up a month later on the 5th of May, when I was coming around and the nurse was trying to wake me up, and I gently squeezed her hand to acknowledge that I was hearing her, but I had lost all sense of direction. I was confused and feeling very, very vulnerable. I didn't know where I was for a while, and then my memory started slowly coming back to me, and I realized what I'd gone through. But in that month, when I was on the ventilator and sleeping, I didn't realize what my family went through, my family were on a daily basis. They were told to brace for the worst. There were a number of occasions when I was very close to death. I had several kidney dialysis, which I never thought I would ever have in my lifetime. Yet the critical care staff at Royal Preston Hospital persevered. They tried numerous techniques, and they got me through. I'm one of the very few lucky ones who've come out of critical care unit with COVID-19 and survived and now live to tell the tale. It is so humbling that so many people have prayed for me. I have the holistic group, Kushal Kaka's holistic group, apparently were sending me Reiki. I'm sure all those things have come to my rescue, and the love of people and the prayers have been answered, and I made it through. It was a very tough time. Whilst I was in hospital, my father was taken in hospital. I'm guessing through the pressure of seeing me and her in hospital. So at one stage, both the father and son were in the same hospital. But thankfully, my father was discharged a week later, and things turned around for me despite how close I came to death. And I managed to come out of hospital off the ventilator a month later. But even after coming off the ventilator, I had during my time in ICU, they put a tracheostomy. They did a tracheostomy on me, so there was a hole in my throat that was put in to help me breathe properly. And eventually, after I'd come out of ICU, I was moved to a respiratory ward where I began to recover through the excellent support of the staff who cared for me so much. It's unbelievable. Eventually, I was given a voice box, which helped me to communicate when people were ringing me on my mobile phone just to see, and the joy they must have felt when they were talking to me because of the situation I was on was tremendous. I had taken precautions before lockdown, but obviously didn't wear face masks. At that time, they weren't very readily available, and didn't think it was going to happen to me, but it did. And I took a toll for the worse, possibly because being Asian, overweight, all those things contributed to me catching it more than other people. But as I said, I've made it through. But after coming off the ventilator, I had very little movement in my fingers. Friends and relatives weren't even sure how I would recover, whether there would be any substantial changes to life that I would have to make, whether I would remember anything, remember my friends and family, whether I would suffer any other side effects. But thankfully and mercifully, I have managed to recover to the level before the COVID-19 attack. But it meant I had to have extensive rehab at Royal Preston Hospital, and I was bedridden for at least a month, during which time I was totally dependent on the hospital staff, who had to wash me, clean me, and that by far was one of the most depressing times of my life. Having somebody to clean me was extremely had a big effect on me, so much so my family were concerned, and they had to bring in a psychiatrist because they felt I was feeling very, very there was some psychiatric, maybe I needed psychiatric, but it wasn't the case. It was just a blip for that moment in time where I accepted that I had to take the help that the hospital staff gave me, who assured me that whatever they did it because it's their job. But that's not enough for me. As far as I was concerned, they were going over and above their call of duty, having to clean somebody when it's not themselves. But they did all this for me, and I'm eternally going to be grateful for looking after me. But this is a situation I was in. I couldn't clean myself. I couldn't get out of bed. I had to learn to stand. I had to learn to walk again. I even had to use a Zimmer frame I've seen people with Zimmer frame, but I never thought I would be able to see Zimmer frame such early in life. But I had to use one just to get around during my rehabilitation. As I said, the physiotherapists were regularly encouraging me and pushing me to learn and to show me how to stand up and to take the first few steps. Eventually, I managed to, I was given my own room where I had my own ensuite where I could shower. But again, somebody had to be near me just in case I fell. So this is a state from someone who is relatively independent. I was in a state where I was dependent a lot, more or less completely with other people. This is what COVID-19 does to you. It brings you down to your knees. But mercifully, again, as I said, through the grace of God and the power of prayer from friends and family all worldwide, I have recovered. And today, a year on, I am back to more or less doing what I was capable of doing before. Please look after yourselves. It's a horrible disease. You need to take precaution only to protect others from getting the virus. Thank you. Bye.
Hi there, my name's Dave, and I've just been asked to talk to you a little bit about my COVID experience, basically, and how I felt whilst I had the dreaded illness. I caught it about mid-October, something like that, and yeah, it was a difficult time. Just to tell you a bit about myself, I'm 36 years old. I feel, I'm no spring chicken, but I feel, physically fit. I've always classed myself to be quite a fit person. I've played rugby and football all my life. I still go running. I did the Manchester Marathon recently. So, I had no concerns about, my health. So I just thought, if I caught it, I'd be fine. My main concern really was for my parents and my granddad, who was ill at the time. Absolutely no concerns myself. In fact, my sister-in-law, who is recovered from cancer, she caught COVID, and she said she felt tired for a couple of days. So I thought, if I get it, I'll just have to self-isolate, stay away from parents and everybody, and then come out and just get on with life, really. I work in a children's home, so I knew I was quite vulnerable because you've got 11 members of staff who, we all mix different shifts, and obviously they go home to their own families, and then come back in, so we're all mixing with sort of 11 families, if you know what I mean. And then you've got the young people, who are like between 13 and 17, and as much as you try and keep them in, they're going out, coming in. We know that they'll be seeing friends and things like that. It's just life, isn't it? As much as you try and get them to adhere to everything, they don't. So we knew we were vulnerable, and there's, out of the 11 members of staff, there's 4 of us who we know already who've had COVID since it began. So it's it is what it is. Some of us have had it worse than others, but that's the thing with this illness, isn't it? It affects different people. But when it was me, how I was affected, I was actually redoing my bathroom because there was rotten floor and rotten tiles and silicone and stuff. So I was doing that, and about 12 o'clock I just started coughing. I thought it must just be the pores in the air and all the rotten wood and things like that. but it was a real hacking cough. And I'd cough for like 20 minutes, then it disappeared. So I was just like, all right, well, there you go. And a couple of hours later, I'd start again for another half an hour, and then it'd stop. And I'm thinking, oh, I'll be fine tomorrow once it's all out of my system. The next day, the coughing got worse, a bit more frequent, bit more kind of hacking, more aggressive. But then I started to develop this really bad headache that was just like straight over the front of my head there. And I mean, it was absolute agony, and obviously made worse by the coughing. And I was getting quite hot, and I was like, oh, hang on, I've seen this in the news, and for a lot of the time before that, when you're just in your normal day of life, you're like, oh, you're swallowing, you've got a bit of a sore throat, and you start thinking, because it's in the news all the time, you start thinking, oh, have I got COVID? That always plays on your mind. But all I can say, my experience, when I did get COVID, I knew I had COVID. As I was driving to the test centre, I was just going just so I could prove to work I've got COVID. I was certain I had it. I went, did my test, came back. I think I had to wait 24 hours, 48 hours, something like that. So my wife threw me into the back bedroom, and that's where I lived for the next 10, 11 days. The first few days, it was just this agonizing headache that just got worse, throbbing pain, hacking cough, non-stop, absolutely non-stop. I can't tell you how bad the cough was, but then the sweating, I mean, like I could wring my t-shirt out in the morning. It was soaked onto you, and he was so hot and so sweaty that you take the duvet off you, but as soon as you took the duvet off you, you're suddenly then shivering when you've got these cold shivers. So then the duvet's on, it's the sweating again and the coughing. It was just impossible to sleep, absolutely impossible to sleep. And that's what it was like for the first 3 or 4 days. In terms of eating, I couldn't eat at all. I just lived off a diet of water and fruit gums. It was the only thing I could get down me for the first, 3 to 4 days, really. My test came back after the second day saying I was positive, which, I knew I was, so I told work. And then you get this like flashing red square that says, 10 days you've got to self-isolate. And then, wake up the next morning, it's 9 days you've got to self-isolate, 8 days, and it's this countdown. I'd got my boss ringing me all the time at this point, which I don't blame him for. He's got to organise everything, because it's not just me being off work. The 2 people I was on shift with are off work for 10 days. The kids have got to supposedly self-isolate in the rooms, and, it's a huge thing for work. So he was ringing me all the time, and I really didn't feel like talking to him. But he's then ringing me throughout the whole thing, going, after your 10 days isolation, you'll be in, because I think everybody thinks, you do your 10 days isolation, and then on the 11th day, you should be back in work. Well, I mean, it just doesn't work like that. I've got one colleague who got it. She's 42 years old, quite fit and healthy, doesn't smoke, all these kinds, the usual stuff. She caught it, a month after me. She's still off work, so she caught it mid-November. It's now March 21, and she's still off work. She struggles getting up the stairs, and she's got an inhaler. So, I went back to work far too early. I was still really tired and stuff, but by the by. But you've got the work pressures as well, and the guilt that I was like, have I brought it in? Is it my fault? And I'm sure my manager wasn't happy with me at all. But yeah, so I had that for the first 4 or 5 days. The shivers, the sweats, the cough, the headache, the no eating. It's horrible. After we got to about day 6, I think, the coughing became less frequent. Still have the odd fit, but less frequent. Still a bit clammy, not as bad. Headache had gone. Starting to get a bit, I might have a bowl of soup and some bread. So I was starting to think, I'm over the worst of it now. I'm starting to think, I can see, there's light at the end of the tunnel. But then, it was if I kept getting symptoms, sort of like when I had one symptom, then the next symptom, suddenly the fatigue hits you. The fatigue was probably the worst part for me. Well, I don't know, it's close, but the fatigue was awful. It was, I'd get out of bed and make a cup of tea, and I'm literally holding on to the sides in the kitchen, just going, please boil, you know, I'm feeling so weak, I need to get back to bed. I'd make my cup of tea, I'd drink it, and then I'd just sleep for 6 hours. That was so much energy went into do that. I'd wake up, and then obviously I've been sweating a bit, you know, I'd get in the shower, again holding on to the shower, just thinking this is the longest shower of my life. I just crawling back into my bed, then I'd sleep overnight, you know, for another 10 hours. I'd wake up, cleaning my teeth felt like I was running a marathon. Just unbelievable. And then back to sleep for another 7 hours. You know, that's what it was. About day 6 to day 9, I'd say. That was really tough. But once the kind of fatigue had disappeared, and this is where that was the end. And each day I was getting stronger and stronger. It got to, like, you know, day 10, and I'm thinking, well, funnily enough, the day 10 at midnight, my isolation period was over, and then the whole country went into lockdown. So I was locked in the house again. But that's the way it was. But then suddenly my taste and smell disappeared. And that went on for, I remember I was just trying anything. I was getting like pickled onion Monster Munch just to bite into it, and it was just like eating cardboard, you know, absolutely nothing, no taste whatsoever or smell. And then the problem was that went on for about 3.5 weeks, and then you start panicking, thinking, will I ever get this back? I mean, so I was back in work about 16 days after catching COVID, and I still didn't have my taste. I did, you know, for 2 weeks after, you know, I was free from COVID, 2 or 3 weeks after, I still didn't have my taste. So you're Googling it, you know, how long is this going to take? So some people were saying 6 months on Google. Some people were saying 1 week, some people in 2 months. And I was just like, honestly, the delight when one day I just bit into a bar of chocolate, and I was like, I can taste it. I mean, it was just amazing. But you do, that's on your mind as well. You panic about whether you're ever going to get it back or not. So that was the experience for me. All I can say is, in my personal experience, COVID is massively underestimated, how bad it is. And you sit there, and even when I had COVID, I'm feeling like I'm dying. You know, you see people marches, you know, against lockdown and all this. You know, the government are just trying to silence us, and all this conspiracy theories, and it's just the flu. I promise you now, it is not just the flu. It is 20 times worse than the flu. It's horrendous. I wouldn't wish it on my worst enemy. And if getting a jab means you don't get it that, you know, as bad, or you don't get it at all, then just stick that jab in me whenever you want, because I never ever want to go through that again. It really is underestimated, and like, I've got friends on Instagram who, you know, and Facebook who go on about, you know, how it's all fake, and you think to yourself, I must be a horrible human being, but I'm only human. I'm sat there thinking, I wish you just got it for a couple of days just to see and feel what it's like, and you wouldn't be spouting this rhetoric, because it's just awful. Anyway, so then I returned to work. And then everyone's making comments, and, you know, you think, oh, was it me who brought it in? But you don't know where, you know, no idea where you do. But then where I caught it from. But then you feel a bit angry, you know, when all the kids are going out and nobody's washing their hands, and because you're thinking, if I go home and give that to my mum and she dies, or, you know, she goes through what I went through, you know, I'd be absolutely fuming. So you know, there's that side of it as well. But it was probably one of the worst experiences of my life. But now I'm luckily I'm back to completely normal. When I go running now, I get with a tight chest, and I'm not as fit as I was. So I'm you know, not as bad as my colleague who's still struggling now with like long COVID. But all I can say is, if it was up to me, get the vaccine, because you do not want this. You know, unless you're one of them very lucky ones who just feels a bit tired. But I was fit and healthy, and it leveled me for 10 days. So get the jab is my advice. Anyway, thank you very much for listening. All right, thanks a lot.
What is
Bye-bye.
long COVID? Long COVID is a term to describe the effects of COVID that continue for weeks or months beyond the initial illness. The health watchdog NICE defines long COVID as lasting for more than 12 weeks, although some other people consider symptoms that last more than 8 weeks to be long COVID. More details of how many people are affected by long COVID are still emerging, but research suggests around 1 in 5 people who test positive for COVID-19 have symptoms for 5 weeks or longer. For around 1 in 10 people, they last 12 weeks or longer. In the initial, acute, phase of the illness, severe COVID-19 can cause pneumonia and respiratory failure, which can result in permanent damage and scarring to the lungs. But COVID-19 is not only a lung illness, it can cause other life-changing complications. In particular, because it can increase the risk of blood clots, it can lead to deep vein thrombosis, heart attacks and stroke. Less commonly, it can cause heart muscle inflammation and heart rhythm disturbances, such as atrial fibrillation. This isn't specific to coronavirus. For example, damage to the heart is also known to happen in severe flu. Learn more about what coronavirus does to the body. The BHF is supporting research into COVID-19 and its effects on the heart and circulatory system. What are the symptoms of long COVID? Most people who had symptoms recovered quickly and were able to resume their normal lives after a few days. But for some, the effects of the virus can last for weeks or months. This has been known as long COVID. For some, it can seem like a cycle of improving and then getting worse again. These long-term effects aren't only amongst those who needed go to hospital, or even who felt seriously unwell when they first caught the virus. Lasting symptoms of coronavirus can include fatigue, breathlessness, anxiety and depression, palpitations, chest pains, joint or muscle pain, not being able to think straight or focus, brain fog. How long does it take to recover from long COVID? Unfortunately, there is currently no way to predict how long recovery from long COVID will take. It's important to note that this isn't unique to COVID-19, other viral illnesses also have lasting effects. Experience from other viruses suggests that most symptoms should go within 3 months, while tiredness may last up to 6 months. But that may not apply to everyone.
It's been just over a year since the start of the pandemic in the UK. And whilst there's much awareness of the worrying and life-threatening symptoms of COVID, especially in those patients who've been hospitalised, there is growing awareness of a condition called long COVID. In the UK to date, we have had 127,000 deaths out of 4.37 million cases. And whilst the vast majority of people recover, there is an awareness that some people who have the disease, anything between 10 and 30%, have prolonged symptoms lasting more than 3 weeks. Estimates are that this could be anything around 500,000, but potentially double this number. People with symptoms beyond 12 weeks are being termed as having long COVID. I'm a doctor who acquired COVID very early on in March 2020, in the first wave of the disease. I was previously active, fit and well, exercised regularly, and I was not known to have any underlying health conditions. The message at the time was, this is likely to be a self-limiting illness in the vast majority of people, and you should feel maybe a little bit fluey, but otherwise you would get better within 2 to 3 weeks. This period of illness has been one of the hardest challenges of my life. Physically, it caused fatigue. I was breathless, and I developed speech difficulties, and this was crucial for my job and my home life with 2 young children. Some of my symptoms still exist to date. I have had to self-manage and access care in unconventional ways, as resources and usual pathways in the NHS had been restricted. Calling upon medical advice from friends or seeking private opinions was the only way I could go, as attending A&E was not advised because of the sheer demand. My general practitioners probably did not have the answers I was looking for and were not able to give me the reassurance. The other challenge was the difficulty in getting assessed. NHS services had changed to a predominantly telephone or digital triage system, so a face-to-face appointment with a clinician was very hard to come by, and follow-up care even harder, whilst services were dealing with acute problems mainly. So the main place I found support was online groups, and around 2 to 3 months in, I stumbled across a long COVID group. It was relief. It was a sense that I'm not alone here, that my symptoms that have been persisting for several months, others too are experiencing this, and almost validated what I had been feeling. I came across a doctors group which had over 1,000 members, and all of these are medical professionals who have acquired COVID at some point over the last year and have had lingering symptoms. And this has invigorated many of us to share ideas, to share information, to share hypotheses about what could be going on, and also empowered us to educate others. The COVID-19 pandemic has demonstrated that those who are most vulnerable in our societies carry the greatest risk and the worst outcomes. It has highlighted the discrepancies and inequalities that exist in the world around us, in our social structures in terms of race, education, poverty, and other health determinants such as pre-existing conditions, so those patients with cancer, diabetes, and not to forget mental health problems, all seem to have worse outcomes from COVID, both acutely and are being seen to have more long COVID. I've heard countless long COVID stories, and all of them carry a theme. This is a new disease. Patients have unexplained symptoms, yet the resources to listen to them, investigate, refer and rehabilitate them have been lacking, partly because the NHS was on hold, worrying about those with acute symptoms, but for patients with less acute symptoms, or symptoms which didn't fit with what was being described, this led to a lot of frustration and stress. And when there was so much uncertainty in people's lives, nobody really had answers for people with lingering symptoms. The physical symptoms that people experience vary from those affecting the heart, the blood vessels, and the lungs, with chest pains and breathlessness attributed to either inflammation or clots or scarring of the organs. Another system of the body that's been affected is something called the autonomic nervous system, which helps to keep our bodies in balance and in check. This has also been noted to be affected with symptoms of palpitations or dizziness. Some patients report neurological or psychiatric symptoms, such as brain fog, where they're unable to think clearly. And this impacts on slowness of thought, on memory. There are other neurological phenomena that have been described, including mini strokes and also seizures. Another group of very strange symptoms include immune phenomena, such as rashes and allergic reactions, diarrhea, or passing urine many, many times a day. It's all been quite strange, and for a lot of people who've been suffering, they just don't have the answers. There are various theories, however. Some feel that the virus lingers on in the body. Others have said that this is an immune reaction that is resulted from the virus, and that has gone into overdrive and the body is fighting itself. Others have said there is something to do with one of the components in the body cells called mitochondria, which are not functioning properly. And finally, there's a consideration that this is indeed a disease of blood vessels and hence affects various organs in the body and has so many unexplained symptoms. Finally, one must not forget the impact of the trauma of the infection on patients who are living with long-term uncertainty after acquiring COVID. This has impacted on their health, well-being, on their livelihoods, and on their relationships. Like many others who have had prolonged symptoms, I have felt like a reluctant pioneer in a quest to try and understand and educate others about this condition. I don't have the answers, but I have a story, as do many others, and we have had to navigate the healthcare system ourselves in order to get help. We need to recognise the need to investigate and rehabilitate our patients, and we need the resources to do so. There has been very little evidence for clinicians in how to manage long COVID patients. The patterns of disease are unexpected, and particularly because they are occurring in younger and fitter people, clinicians do not suspect that there could be underlying pathology. These patients need investigation and reassurance and rehabilitation. We need to keep an open mind about possibility. And most of all, we really need to start listening to our patients again.
Hello, my name is Bayer Rigo. I'm an executive coach and a mentor, and speaking very recently to Rajiv Gupta, and thanks Rajiv for giving me this opportunity to share some of my thoughts around mental health, mental well-being, and particularly associated with COVID and the effect on the Black and minority ethnic grouping. COVID, well, we've all endured it. It's been long-lasting. It has been devastating. It has been really difficult across the board for us all. And there are issues. There are issues that we could have addressed differently. There are issues that we could be addressing differently now. But I'm more interested in what solutions could we be thinking about moving forward. But in order to take that on board, we also need to think about how's it affected the Black and minority Asian community. What's been the effect on the business community as well? That's my primary interest, is in the business community, because across the board there has been a number of issues that really have been missed and failed to be appreciated and understood. Without shadow of a doubt, on a socioeconomic level, we have been highly represented in numbers in terms of the effect on our mental well-being, physical, and also social and healthcare. We are at the front line. Our businesses have been hurt. Transportation has been affected by this, and all the stats seem to suggest that the majority of Black and minority ethnic people have fared worse. And in the business sense, that has hit us hard in a number of ways. If you look at how or what the stats say around grant applications, restricted grant applications, sources for funding, we haven't fared well. If you look at the major parts of the business sector, economy that have been hit hard, we've been hit hard as well. Hospitality, food, catering, transport, amenities, entertainment, where you would see a predominance of Black and minority ethnic businesses have been hit hard. Do you know how much we produce a year in terms of a financial economic blueprint on the economy? 250 bill. That's a lot of dosh. It's a lot of money. And yet, if we look at the wider picture, the bigger picture, there hasn't been a really good process or a platform to address this. I've been fortunate enough to be working with the likes of Diana Crouch, who is part of the all-party parliamentary group for Black and minority ethnics in Parliament, working on a BAME COVID response. And I reckon you should go and look at that paper, look at that document. It is full of data and details as to how and why we've been so affected, but most importantly, some solutions to address that. And I'd like to share that with you too. Access to finance. As a business owner, myself, entrepreneur, working with some of my clients, one of the main things that they've been frustrated with is access to finance or no access to finance. Not because it hasn't been out there, but it hasn't been promoted or shared in a way that they can find accessible and or transparent. There's an issue of trust. We all know that within certain communities, trusting other communities can be very difficult. Tailored business support. Well, let's be fair, there hasn't been any really. If you have coaches and business advisors and consultants running around left, right and centre trying to make it the money, it's going to be very difficult for the smaller minority ethnic groupings who are primarily micro business, individual businesses, just started up, going out to seeking that support. Financially, it's going to be crippling through them. And actually as well, at a bigger strategic level, there's been structural and systematic banking issues. And again, the APPG report on Black and minority ethnics and COVID impact has highlighted this, and they are working together with some big banks to see how they can address some of the digital exclusion that has persisted, and also the poor information and or sharing in terms of the loans and support available through the banking process. One of the things that I think and I feel strongly about is community-based services. There's been very little collaboration until very recently, and I have to take off my hat to my local authority, London Borough of Lewisham, in its holistic approach, its collaborative approach, working with partners across the board from the Federation of Small Businesses, the Chambers of Commerce, to the small business people in and around Lewisham, working with different facets and directorates within Lewisham to address the anomaly and the poor service delivery at that time to small businesses in Lewisham, primarily Black and minority ethnic businesses. So what we're going to do to move forward, what I would suggest is that we look at some of the main criteria. One size does not fit all. There is a process, obviously, that needs to be followed, but this needs to address some of the systematic failures that exist already. I've already talked about a holistic and collaborative approach that many local authorities are taking. London Borough of Lewisham is doing that. Digital inclusion is key to moving forward and enable small businesses to take advantage of technology and take advantage of the disparate situation that they may find themselves in. And I like to think about local community support, a local burgeoning business community that can support the smaller businesses, and a predominance of Black and minority ethnic businesses in this space requires that local community support. And with that comes improved communication and consultation. The idea that it is out there doesn't mean it is out there for those who aren't told it's out there. It's how we communicate it's out there. That's going to be key. Build confidence, build trust, improve communication, create collaborative mechanisms to engage with these businesses so that there is an understanding and a know-how in order for these businesses to grow. I am talking and working with the likes of Rajiv Gupta and various platforms to really bring to the fore the needs of the small business community, and primarily the Black and minority ethnic business community. If you want to know more, my socials are out there. I'm on LinkedIn, I'm on Facebook, I'm on Instagram. Bayo at Bigo Coaching. That's all you need to do. It's great talking to you. I look forward to participating and contributing more.
Hello, my name is Dominic Harrison, Director of Public Health and Wellbeing Blackburn with Darwen Council. And I'd like to thank the National Forum for Health and Wellbeing for this opportunity to speak to you about long COVID, or post-acute COVID-19 syndrome, as it's now being also referred to. Firstly, it's worth saying that long COVID is really an umbrella term for a range of different conditions, symptom clusters and syndromes. So we suspect it's not one single disease. And there are probably three phases of long COVID. First, an acute COVID-19 infection phase with signs and symptoms of COVID-19, and this is likely to last up to 4 weeks. Then there is ongoing symptomatic COVID-19 with signs and symptoms of COVID-19 lasting between 4 and 12 weeks. And then we have what we're really referring to as long COVID, which is post-COVID-19 syndrome. Now this has signs and symptoms that develop during or following an infection of COVID consistent with COVID-19 and one that continues for more than 12 weeks. Now, of course, it's worth stressing that long COVID can affect both physical and mental health, so both of those areas of well-being will be affected by long COVID. And the numbers vary according to which research papers you read, but I think generally we think that in those three phases I've described, about 14.5% of people who have had COVID will still have COVID-19 symptoms after 28 days. About 5% will have symptoms after 8 weeks, and about 2.2% of all those who get COVID will still have symptoms after 12 weeks. Now, NHS England has put some money towards development of primary and community and rehabilitation care, about 10 million at the end of last year for long COVID. And of course, NICE has produced some guidance on their assessment of what evidence there is. But of course, that evidence is developing week by week, as has the Royal College of General Practitioners. Lancashire and Cumbria Directors of Public Health and the Public Health Network have commissioned some work on the likely impact of long COVID across the integrated care system in Lancashire and Cumbria. So that area covers about 1.6 million population. And we think about 33,000, just over 33,000 people will still have COVID symptoms after 12 weeks in Lancashire and Cumbria. And that, of course, is based on the infection rate numbers, the cumulative infection rate at the end of February. So that number will be slightly higher now and may well rise as we go through the summer. So long COVID is going to be an enormous challenge to an NHS, which is already facing an avalanche of cases of unmet need, undiagnosed illness and exacerbated long-term conditions that have been not seen, not treated, not managed during the COVID-19 year of 2020 and of course in the spring of this year, when the NHS had to step down many routine services in order to care for people who were acutely ill with COVID. So the system is going to be under stress in both hospitals and in primary care in particular over this next year. It will also then have, on top of that long-term condition demand, have the long COVID cases. And those cases will overlap probably because people who have been at risk of COVID and of severe effects of COVID and of long COVID do also have those long-term conditions which may have exacerbated over the last year through lack of early intervention, treatment or screening for continued illness. So the NHS is going to be very stressed in being able to manage this well, but there's a strong commitment from the NHS and colleagues working alongside the NHS in local government, adult social care and public health to address the challenges that long COVID presents. Most of the evidence is suggesting that the earlier you can identify any post-COVID symptoms lasting longer than the first 4 weeks, the better. And of course, a lot of the interventions are well-being interventions, both mental health and physical health. Physical activity, clearly really important in that. And of course, for those who have had post-COVID symptoms for over 12 weeks, a more detailed, in-depth referral and assessment is necessary, and many local authority areas and NHS areas have developed those services which are accessible on referral from the GP. So we're making some progress in understanding the challenge and addressing it, but more needs to be done. The final thing I want to say is that many of the syndromes, symptoms clusters and conditions identified with long COVID are very similar in nature to those identified for many years by people with ME or chronic fatigue syndrome. And some of you will know that those kinds of diseases have been, in a sense, orphan diseases. They have had less research and less positive treatment options available for people who've suffered from them. And in many cases, the people who've suffered from ME and chronic fatigue syndrome have had the severity of their disease questioned by many people and feel underserved by both research and treatment and care. So we hope that as the long COVID research progresses, as we understand more about what's causing it and how we treat it most effectively and how people can recover from it, that will lead into other improved treatments for other groups of the population with long-term chronic disease. Of course, given the short time scale, we don't know exactly how long COVID could last in an individual. So that is something further research needs to be undertaken on, but of course we'll only know that with time. So that's where it is, and many of us are working to improve the health and well-being of those with long COVID. I'm delighted that the National Forum for Health and Wellbeing is addressing this issue as well today. So thank you very much.